Good morning, ladies and gentlemen, distinguished guests and presenters. My name is Kelvin Glenn. I am the convener for your webinar today. Today, we're going to be talking about Together Towards a Future Without Fetal Alcohol Spectrum Disorder. This is a webinar that is brought to you by the Eastern Cape Liquor Board, Fast Facts, Distel, Rhodes University, and ourselves, Kalume SA. We have a distinguished panel of guests from Fast Facts, Distel, Rhodes University, the Department of Health, the Department of Social Development, and the Eastern Cape Liquor Board. We have an interactive session where we'll be sharing best practice, we'll be giving you case studies, and we will be having an interactive panel discussion around fetal alcohol spectrum disorder. We do hope that you'll enjoy the presentation, and we look forward to your questions and facilitating those questions with our panel throughout the session. Unfortunately, due to restrictions with travel and the limitations with COVID, we would have liked to have had this as a physical event, but as a result, we've had to turn it and pivot it into a virtual event. However, the positives of that is there are many guests that have joined us from around the country, and we welcome each and every one of you. Ladies and gentlemen, my name is Kelvin Glenn. I will be your host today. Just a couple of housekeeping rules. Please make sure that during the presentation, your computer or cell phone is muted and that your video is off. We do request this because it interferes with the presentation and the bandwidth. In this facility, you will see that there is a chat box, which is a little speaker bubble. We encourage you to please put into the chat box, number one, where you're from and what is your organization, so that all the other colleagues on the call that have attended this webinar today can see who else is attending. This is one of the challenges with virtual. Had this been a physical event, we all would have been in the room, we would have been able to introduce each other, and we would have made new friends. The challenge with virtual is that it's you and all of us on the other side of your computer screen. So we do ask you that you just pop into the chat box your name, your organization, and where you're from. And then throughout the presentations and the discussions today, if you have questions, please pop them into the chat box. We will be monitoring that, and we will be facilitating Q&A. Unfortunately, we might not be able to get to all the questions today. If we do not, we will respond to you via email, and the panel expert will hopefully be able to answer your question if they cannot answer it in the time that we have allocated for Q&A. Lastly, ladies and gentlemen, we are recording this session, so the entire webinar is recorded. We will send a link to your email in a day or two with a copy of that recording so that you can go and download it or rewatch it or share it with your colleagues. However, because it is being recorded and it will be put on a public YouTube platform, we do ask that anything that you pose as far as a question or a comment, that you consent to that will then be in the public space once that is uploaded into the YouTube channel. If you wish to remain anonymous when you're posting your question, please post the question to myself, Kelvin Glenn, as the host, not to everybody, and only I will see that question. Alternatively, a lady by the name of Tamsin Palmer is also on the call and she is assisting me. So if your question is you want to remain anonymous, please pose that question to either Tamsin or myself. We will still pose the question, but we will pose the question anonymously and we will not mention your name. Just a little bit about what to expect from today. So there is our agenda. It's a very full agenda. We will be hearing from what is FAS and what is FASD, the introduction from Distel, overview of Fast Facts, an overview of the Fast Facts program, wonderful research that's been done on the spectrum disorder. We're then going to have a very interactive panel discussion. We will then finally go to Q&A that has been presented in the chat box. And lastly, we will be summing up the day and highlighting the takeaways. You will notice that we have allocated a very short comfort break for us to be able to just refresh, grab another cup of coffee. The recording will remain on and the webinar will remain live during the comfort break. So you do not need to disconnect and reconnect. Just leave your computer on and rejoin us after the comfort break. All right, without further ado, I would like to call on Pastor Jeff Nzamande to present us with an opening prayer. I just want to stop sharing. Pastor, will you please, there's Pastor. Pastor will be doing an opening prayer for us, and then we will carry on with the formalities. Over to you, Pastor.
Good morning to everyone, all the stakeholders that are here today, together with the panel. Let me greet all of you in Jesus' mighty name. I'll just make a very short prayer this morning. I would like us to read from the word of God from the book of Psalms 127, only verse 1, then I'm going to pray. It reads as follows from NIV. Unless the Lord build a house, its builders labor in vain. Unless the Lord watches over the city, the watchmen stand guard in vain. Here we read it from the book of David, and these words are from Solomon. Well, Solomon is known as a wise man in the world. He noticed people who were struggling when they were doing or building things just because God was not part of those. Even these days, we have so many things we are busy building. We are busy building our legacy for our children and our community. We are busy with our better future so that we won't struggle like this in future. We are busy building our companies, busy building our careers. But today we are meeting here, busy building our future. We're busy building future for South Africans, and as good as it is that we are busy building for a future for our South Africans, we are doing. We need to invite God in whatever that we are doing. So now that we are gathered with the purpose of building our future generation, but there are so many things that need God to be part of our life. So each and every one of us need to invite God. Need to invite God in your personal stuff. Need to invite God in your busy schedule. Need to invite God. Even today's meeting, we need God. We need the intervention of God. We may not have a fruitful meeting if we don't have God in our lives. And the Bible says, if you continue build a house without God, your labor is in vain. Not that it doesn't come true, but you struggle for your things to come right. So you need God in whatever that you are doing. Let's just close our eyes so that I will pray. I will make a very short prayer, then I'll give it back to the program director. Our Heavenly Father, we want to thank you for this wonderful morning. We thank you, Lord, that you are part of us. We thank you, Lord, that you're giving us this opportunity to invite you, Lord, even in this meeting. We invite you, God, that whatever that will be discussed in this meeting, be part of it. And Lord, lead us, Lord, into that right direction in the name of Jesus Christ. We do not have another God that we may go to, that we trust, but Lord, you are everything in our lives. Help us, Lord. Help each and every one so that, Lord, we'll have a fruitful result of what we are about to discuss. In the name of Jesus Christ, Father God, we pray. Amen and amen. Thank you.
Thank you so much, Pastor. Thank you for those inspiring words and for leading us in prayer and blessing this webinar today. Ladies and gentlemen, just one more housekeeping is obviously with virtual, there will be a 30-second delay where I need to retrieve the respective PowerPoint presentation and put it on the screen so you can see the presenter's PowerPoints. So I do ask that you bear with us for these changes between our panel discussion. So while I am bringing up the next presentation, I'd like to introduce Ms. Jeanette Stradom, the Marketing Manager from FastFacts. And Jeanette will be taking us through what is FAS and what is FASD. Jeanette, if you can put your camera on while I get your presentation ready.
Okay. Good morning, everyone. Can I start? Fetal alcohol syndrome. I was asked to explain a little bit about fetal alcohol syndrome and what it is. Fetal alcohol syndrome, also called FAS, is a congenital syndrome associated with the consumption of alcohol by the mother during pregnancy. In other words, it's just symptoms associated with the syndromes. They're all evident from birth. FAS, next slide. Thank you, Calvin. FAS is the abbreviation for fetal alcohol syndrome. I've put on the slide, I've actually put the definitions on, but where FAS is the most extreme and severe case. Children born with this FAS disability have specific facial features or abnormalities. They've got growth retardation and developmental abnormalities of the central nervous system. The effects of drinking during pregnancy can vary very widely. Some can have little or no effects, and then others may be severely affected. Factors that influence this is the amount of the mother drinks during pregnancy, the specific time she drank during pregnancy, and then obviously the mother's nutrition. If the nutrition is good, the baby will be nice and strong and hopefully have not as many effects. The brain development, though, throughout the pregnancy and then is still very vulnerable. And you can see the picture as well that was taken of a FAS brain on 6 months and then a normal brain, the difference that you see. What we should remember is the FAS, that what we're talking about, the FASD, is the spectrum disorder. This basically means there's a range of signs and symptoms that vary when babies are born who were exposed to alcohol during pregnancy. What we should remember is the 3 affected areas when a baby is born with FAS or partial FAS. It's got a physical effect on the baby. It's got neurocognitive effect. This has basically got to do with the nervous system and the brain, and then behavioral effects that we see. Next slide. Or FASD is a challenge in most parts of the world, and you'll specifically see in South Africa that we have some of the highest rates of FAS, specifically the Western Cape and the Northern Cape. And FAS and FASD has had a huge impact on our communities and South Africa as a whole. In our surrounding area, we find where our head office is here in Worcester and Wellington, the community has been vastly affected, not only with us here in the Western Cape, but all over South Africa and all over the world. We've almost got, according to the statistics that we've received, the latest, almost 13 to 20 people in every 100 people are affected by these FAS spectrum. The negative impact of FAS individual on our social economical environment is totally misunderstood and underestimated. The slide I've taken from the internet, from the medical board, and when I saw this slide, I was absolutely stunned the first time when I realized the effects that FAS has had on our community and country as a whole. If you look at the slide, you'll see typical features of FAS children or the spectrum of FAS children. And just to mention that you've got a slight better idea. Small eye openings tend to be features of FUS-affected people. A thin upper lip, smooth area between the nose and the lip, sometimes a low nasal bridge and a short nose. Thank you. Next slide, Calvin. Mentioned here are the potential secondary disabilities with children fall in the spectrum of FUS. I've written them all down. Some children might, like I mentioned, some might be affected, some might not have as many symptoms due to the factors mentioned. We must ask ourselves, what is this costing the child? And are we okay with the amount we are doing to prevent this? Are we effective? Could we be more effective? Next slide, please. On both a financial and a personal level, everyone is affected by the abilities and consequences of FUS. The secondary disabilities of people with FUS cost the fiscus more than any other disability. The secondary disability with FASD could have any of these factors mentioned to a more or lesser extent. And this is, if we read through these mentioned factors, it is basically the whole South Africa affected. Few people realize that the severely troubled teenager, the addicted prostitute, the homeless beggar, or the man charged with killing his girlfriend's baby may all behave as they do as a result of brain damage caused by the mother's drinking during pregnancy. FUS is definitely something that impacts us all. Firstly, the unborn without a choice, his and her whole future is destroyed. And secondly, the people in the community affected by the ripple effect of the secondary disability, also without a choice. Next slide. FUS is 100% preventable, but unfortunately, 100% irreversible, and therefore calls for extensive awareness, training, and intervention campaigns. I would like to end off with a quote. Drinking during pregnancy is linked with disaster, personal disaster for the bright-eyed ones, disaster for their families and their hope for the young, and disaster for society as we struggle to pay the huge price of this destruction. This was Prof. Anne Strasbourg that quoted this. Thank you.
Thank you very much, Jeanette. Ladies and gentlemen, that was Miss Jeanette Schroeder, who is the marketing manager for FastFacts. Thank you very much, Jeanette, for that presentation. I'm just going to get the next presentation ready. Our next speaker is Mrs. Sonia Morkel, who is with Distel Limited. And Sonia is going to be sharing with us and introducing us to Distel and Distel's support on addressing FAS and FASD. I just want to get Sonia's presentation up. Sonia, if I can ask you to put your camera on.
It says you cannot start your video because the host has stopped it, Calvin. Okay, there we go. There we go. Thank you so much. Can you see me? Because it still gives me the same message that I cannot share my video. Can you see me, Calvin?
Yes, we can see you, Sonia.
Okay, thank you very much. I'm just waiting for the slides. Good morning, everybody. I would just like to greet you in the meantime and say welcome to this session this morning. We are so honored to have all of you with us and honored to be sharing this information with you this morning. I'm the CSI controller at Distel, and I form part of the Distel SA structure. I still can't see my specific slides.
Calvin, can you give us an update on the presentation? Please just bear with us for a sec.
I'm just loading the slides. 1 second for me.
Go.
All right, so I'm just going to play it from the start. Are the slides showing?
Yes, it is, but not full screen yet.
Okay, it should be full screen now. There we go.
Thank you so much. Will you be able to see if I give you the signal, Calvin? Just checking. We
Yes,
can go
Sonia,
to,
go ahead. Go
okay,
ahead.
we can move on to the next slide. Thank you. Thank you very much, and thank you for bearing with us, everybody. Yeah, so I'm from Distel Limited. Just to give you a quick, very brief overview of who and what Distel is. So Distel is the only listed South African-owned alcoholic beverage company in Africa. The purpose, as we've identified it for ourselves, is creating memorable moments, crafting a better future for everybody. We are a producer of alcohol over 3 categories, namely ciders, wines, and spirits. We are a level 3 BBBEE company with approximately 4,550 employees, and that is nationally and internationally. And there are various ways in which we invest back into our communities. And there, more specifically, I would just like to highlight the 20 million harm reduction in harm reduction programs. And also, I would just like to mention that this is specifically not specifically from the CSI budget or the budget that sits with the Corporate and Regulatory Affairs Department, but it's across various business units in our company. The 20 million specifically, if I can get back to that, is made up from a CSI investments that we have over various categories, but also an investment in aware.org, which is our industry body, an industry body for the alcohol industry. And there are various projects nationally that they focus on to promote responsible drinking and to reduce the harm that is caused by the abuse of alcohol. Thank you. Next slide. And this is just to give you a very brief idea of what our top products are. Some of them may be familiar to some of you, and it's products across the 3 categories in which we produce, namely ciders, wines, and spirits. Thank you. I would just like to give you a further overview of more specifically our sustainability strategy and where everything and how everything fits in with each other. This is also where I'll give you a bit more information on our relationship with FastFacts and FAR and how we've come about to support these projects. So first of all, I would just like to share with you that our sustainability strategy is based on the following. It is aligned with the United Nations Development Goals. And as we all know, there are 17 of them. We're not aligned to each and every of those goals, but we align to some of them, and I will highlight them just now. Our sustainability strategy is also aligned to 4 pillars, namely purpose, planet, people, and profit. This is what we focus on in our sustainability. Furthermore, there are 5 key themes in our work that we do in sustainability and that we focus on and what we believe makes us as sustainable as a company. So first of all, we focus on the promoting of responsible drinking, empowering our communities, achieving transformation, and managing our supply chain sustainably, also empowering our people. And all 5 of those themes are supported through our CSI work as well as across various business units in the company as well. So I'm going to be focusing on promoting responsible drinking, as this is what we will be talking today, we'll be talking about ultimately. So as you can see, promoting responsible drinking also supports 3 national development goals, namely good health, SDG 3, good health and well-being, SDG 5, gender equality, and SDG 17, namely partnership for the goals. Thank you. This is just to give you an overview of what we see as our sustainability highlights. And this is based on what has happened throughout the previous financial year. Once again, you'll see a repeat of our five focuses, namely promoting responsible drinking, achieving transformation, empowering our communities, empowering our people, and managing our supply chain effectively. So once again, I'll be focusing, in the interest of time, I'll be focusing on promoting our responsible drinking and the focus that we have there, more specifically through our CSI work, or the social economic development work that we do. We partner with various organizations, or with two more specifically. It's FASFAX and then FAR as well, or better known as Foundation for Alcohol-Related Research, and then also aware.org that we support in terms of projects that they run countrywide. For us, a highlight was the fact that during the previous financial year, 70.5% of women who attended the Pregnant Women Mentoring Program in the Western Cape stopped drinking as a result of the information and the mentorship and the education that they received through the FASTFAX project. In the Eastern Cape, 88.3% of women in the program, and as a result of the information that they receive and the education that they receive, and most importantly, the mentorship and through the mentors, have stopped drinking as a result of this program. And for Northern Cape, during the 2019 financial year, 95.83 babies tested healthy. They run a pediatric clinic during which babies are tested at the age of 9 months to determine if they are healthy, and that was their success rate. So these are highlights that we are very, very proud of, and it wouldn't have been possible for us to reach these goals and have these highlights specifically if it wasn't for our implementing partners such as FASTFAX and FAR. Thank you. I would just like to give you a little bit of an overview of our relationship with FASTFAX in the Eastern Cape and how we came about starting this program here. Also about the relationship with Eastern Cape Liquor Board, Rhodes University, etc. So we've been a funding partner of FASTFAX for the past 13 years. It started with a program in Worcester in the Western Cape. And in 2015, we were approached by the Eastern Cape Liquor Board Social Responsibility Department for a partnership in East London, Eastern Cape. We were very keen, because we are very keen on supporting and partnering with liquor boards and with government as well. So one of the requirements for such a program to us was that it should be based on research, so that the area with the greatest needs could be identified, and so that the impact of the project could also be measured afterwards. So the Eastern Cape Liquor Board commissioned Rhodes University as a research partner, Distel came on board as a funding partner, and FASTFAX and Eastern Cape Liquor Board together as the implementing partners of the Pregnant Women Mentoring Program, which saw the light in 2018. Measurement and evaluation of these projects are of the utmost importance for Distel. Our management is interested in the percentage of women who stops drinking, so that we can make sure that we are in fact aligned to the Sustainable Development Goals, and specifically in this case, SDG 3, 5, and 17. And we who are more deeply involved with this project, we realize and we know and we see that the benefit and the impact of this program stretches far beyond only these percentages. The women, it's not only the few women who attend the course or who are in the program that actually benefit from this program. Families that they live with, it is their societies, it is their communities. So we see, and we don't only see that through the data and the reports that we receive, but we also know it because we have witnessed, and especially in my, the time that I've been been involved with FASTFAX, I've seen the difference and the impact that has had on the lives of these women. And we've seen it through the live and real life testimonies of these women. when we attend open days, or annual general meetings. So we always have the opportunity to meet the beneficiaries of the project. So furthermore, to Distel, it's important to increase our reach with alcohol harm reduction through our current partners, and we're definitely working on that and looking into that. And the sustainability of our social partners are also very important to us. And therefore, we also support FastFacts with capacity building and also the measurement of their programs to determine what the social return on investment is through the theory of change methodology that we make use of. Thank you. This is just to briefly show you that over and above the investment that we make through our SED work with FastFacts and FAR, Distel has also embarked on a number of other harm reduction programs in supporting national government to also reach their national development plan or support their national development plan. So very briefly, I'll just highlight a few points. During the past year, and especially during the time of COVID, we've supported a number of hospitals in 4 provinces with PPE, such as masks, gloves, visors, sanitizers, etc. We've also embarked on a program with signed an MOU with the Department of Transport, a road safety program, namely Arrive Alive, that focuses on, for instance, drinking, driving, and also pedestrian safety. We have embarked on a program, a responsible trader program with South African Police Services and also the Ministry of Safety that looks specifically at the responsible trading. So here, for instance, we would look at measures such as not selling to pregnant women, educating or teaching traders to not, for instance, sell, to be compliant, to not sell to women who are pregnant, to not sell to people under the age of 18, to make sure that the spaces where they operate are not a nuisance or a disturbance in the areas, and that it is in fact safe spaces. So you'll see on that graph that at the beginning, when we started measuring these traders, about 55% were compliant. And in December, when we measured again, about 85% of these traders were compliant. So great progress is being made there. And then also lastly, we are working together with the Department of Social Development on the gender-based violence and femicide program. And also there we've supported Department of Social Development in a number of initiatives that focuses on homes, on the prevention of gender-based violence, but also on the victims of gender-based violence and people who have been affected. And then very shortly, just to the impact that we've had through these programs, more specifically, is very importantly, there's 766 jobs were created through these initiatives. And it has been counted that the total number of amount of livelihoods that has been impacted through these initiatives comes down to about 51,000. Yeah, thank you. So we can go on to the next slide. And that's it. So thank you very much for this opportunity to also share with you who Distel is and how we've been involved with this program over the years. Thank you so much.
Thank you so much, Sonia, for a very informative presentation, not only educating us on Distel as an organization, but also sharing with such passion as a corporate its commitment to supporting programs like FastFacts and FAR. Ladies and gentlemen, we're going to do a slight change in program because our next speaker is having a connection problem. So we are going to ask Mr. Francois Grobler, who's the CEO of FastFacts, to give us an overview of FastFacts. Francois, if I can ask you to put your camera on while I get your slides ready. I'm just getting the slides ready, ladies and gentlemen. So
Can you hear
apologies,
me?
our next speaker, yes, we can hear you, Francois. Apologies, our next speaker lost connection, but he is going to reconnect and then he will be joining us after Francois. So, just want to get your slides up. Share screen. So just all right, ladies and gentlemen, we introduce Mr. Francois Grobler, who is the CEO of FastFacts. Francois, over to you.
Calvin, thank you so much for the opportunity to be with you today. I want to say thank you to Dr. Ngwebi and Sonia Morko and Professor Catriona for being with us today, and also all the guests. Thank you so much that you are with us today so that we can talk about a very serious subject, namely fetal alcohol syndrome in our communities. Now, the NGO FastFacts is an NGO that we established to do prevention programs in fetal alcohol syndrome, and that is what the name also tells you, fetal alcohol syndrome facts. We give facts through to communities about fetal alcohol syndrome and what is the effect of alcohol on the unborn baby. And we want to prevent that. Our slogan is, we speak on behalf of we speak on their behalf, we speak on behalf of the unborn child, the unborn baby who cannot speak for themselves yet. Now, I think you can ask yourself the question, why did Francois establish an NGO FastFacts? I myself grew up on a farm, and unfortunately, those days they still had the DOP system or the TOT system, where they pay the farm laborers partially with alcohol. And many times I ask myself the question, Francois, for how many women, pregnant women possibly, you gave alcohol during their pregnancies? And yeah, after I grew up on the farm, I went to the agricultural high school in Paarl, and after that I did my studies at the University of Stellenbosch in theology. And even those days, when I worked on a farm one holiday, the farmers still had the DOP system. And I still took part in that system. And now, after I did my national service in the Navy, I I didn't go into a ministry. I actually started working for the Rural Foundation, and they did community work on farms. And they also had programs on alcohol and drug abuse. And one of the areas that we also looked at was fetal alcohol syndrome. We present programs on fetal alcohol syndrome, told women that they mustn't drink alcohol during pregnancy because it harms the child's brain. And then after that, I was with Boskop Training Center, and we did quite a lot of training programs on farms. And then I was involved with the ministry amongst students in Worcester. And during that ministry, some of the youngsters, the ladies, they drank quite a lot of alcohol, and they also, some of them became pregnant. And then me and my wife told them that they mustn't drink alcohol during pregnancy because it can harms the child's brain. And during those time, in that time, the Lord really called me to establish fast facts. And that was around about May 2002. And then we started out presenting programs in the Worcester area and also in other areas later on. Can we have another slide? Our vision, we have a vision of children being born without fetal alcohol syndrome. And our mission is to implement programs that prevent people from taking alcohol during pregnancy. Can we have another slide? Another one. Yeah, we've got actually 3 different programs. The one is the Train the Trainer program, where we go into communities and we train facilitators on, we give them the knowledge of fetal alcohol syndrome and also the training material. And then they have to take the program further into their different communities. Yes, next slide. We also have a pregnant women mentoring program, and that is the program where the STEL is also involved with us. The pregnant women mentoring program, where we train mentors, and the mentors must be a support for the pregnant women who take alcohol during their pregnancy. So they must try and convince these people to abstain from alcohol during their pregnancies. And there's quite a lot of success in that program. As Sonia told you, that in some cases, there's about 70%, and another case in the Eastern Cape, there's about 80% women stop drinking during their pregnancy. So that is also harm reduction. Yeah, can we have the next slide? Yeah, we also provide these mentors with a flip chart, and the flip chart, the whole message is in that flip chart, and they go from home to home and tell these pregnant women what is the influence of alcohol on the unborn baby, and that is a very, very effective method. Yes, Calvin. The last program that we've got is what we call the BOB program, and BOB stands for Beste Opgepaste Baba, Best Care for Baby, and that is a program for grade 6 and 7 learners, and also for adults, where we make use of experiential learning to show children and adults, to teach them what is the influence of alcohol on the unborn baby. Very effective program, and they really remember what we teach them. Can we have the other slide? Yeah, there is one of our facilitators, Herschel Baron. There they are busy planting a bean. That bean has to grow then, and if the bean grows, that is a BOB, a Beste Opgepaste Baba, and that reflects the child of a mother that didn't drink alcohol during pregnancy. Okay, next one. Yeah, that was around about November, I think 2017. where we took this photo. That was the first photo in East London of the coalition between the Eastern Cape Liquor Board, Rhodes University, FastFacts, and obviously Distell as well. That was the first program that we presented in the Eastern Cape, and we are very, very thankful for all the different parties that came to the table and say that it is very important that we must teach the communities about the effects of alcohol during pregnancy. And we are now busy there for for around about 3.5 years. And that is why it is so important for us that we must get together now as different stakeholders, different organizations, so that we can see what must we do that this project will continue in the future as well. What decisions must we take? Who are the role players that must be involved to make this project a success for years and years? And that is why we are so glad for each and every one of you that are present with us today. Next slide. Yeah, FastFacts believe that we mustn't only present programs in the Eastern Cape and Western Cape. We already presented quite a lot of programs in the Northern Cape, and hopefully we will also extend our programs in the future to the different to the other 6 provinces in South Africa, so that we can teach them also that mothers mustn't drink any alcohol during pregnancy. So yeah, thank you so much for attending to our presentation, and everyone, as you say, deserves a chance, and we must be the voice of those children that cannot speak for themselves yet. Thank you so much.
Thank you very much, Francois, for that comprehensive outline on the work of FastFacts and the important work that FastFacts is doing in the community. Ladies and gentlemen, we've managed to reconnect Dr. Masia from the Eastern Cape Liquor Board. So Dr. Masia will be doing his presentation from the Eastern Cape Liquor Board. Magwebi, if I can ask you to put your camera on while I get your presentation ready. Sorry, 1 second. Just close that one. Thank you for your patience, ladies and gentlemen. It is always the challenges with doing virtual events. So over to you, Dr. Masia.
Thank you very much, Kelvin. My name is Magwebi Msia. I am the head of social accountability at the Eastern Cape Liquor Board. Let me greet everyone that is in attendance at this very, important workshop. So I greet all of you. Thank you so much. I will reflect on the following, just to give an overview of who Eastern Cape Liquor Board is and what we do as an organization. Briefly I reflect briefly on the mandate, the core business areas, our harm reduction strategy, the active licenses, the collaborative efforts that we have entered into, the FastFacts initiatives that we have embarked upon as the organization, and then conclude. Thank you, Kelvin. We derive our mandate from the Constitution of the Republic, which enjoins us to facilitate and coordinate the issuing of liquor licenses to the liquor establishments that meet the specifications as per the legislation. And we also indicate that the regulation of liquor industry is not sale of alcohol is not an exclusive responsibility of the Eastern Cape Liquor Board. The local government also has a role to play through their liquor bylaws. The Constitution enjoins them to establish liquor bylaws so that they can determine trading times in their jurisdictions and also develop mechanisms to manage nuisance that arise from the sale of alcohol. The Eastern Cape Liquor Board is established by the Eastern Cape Liquor Act number 10 of 2003. This is the statute that has actually given rise to the Eastern Cape Liquor Board, which empowers it to regulate the retail sale and manufacturing of alcohol, to mitigate against the negative effects of the excessive consumption of alcohol, to enforce compliance with the trading conditions, to ensure that the liquor traders comply with the conditions that are attached to their licenses, to also provide requisite support to the industry to ensure that they developed and they're empowered in order to grow in the business. I do also want to point out that the Eastern Cape Liquor Act of 2003 has been amended. The reviewal process started sometime in 2016 and was completed in 2018. So we're having a new act now, Eastern Cape Liquor Act number 4 of 2018, which was gazetted in March 2019. So we are currently finalizing the regulations, which are the guidelines that will dictate how the provisions of the act are to be applied. There are a few changes. In fact, there are changes that have actually been effected into the new act. One of such changes is that the act now imposes restrictions on the issuing of liquor licenses. For instance, we must now consider the population density when we issue a liquor license. We must also ensure that we consider the concentration of the liquor licenses within that particular area, unlike in the past, where we relied mainly on the consent of the community. But now we have to look at the density of the population and also if there are existing liquor outlets within that particular area. So that is what the new act is actually now prescribing. But also it has actually brought a change in terms of the distance between a liquor outlet and a school, a church, public transport, or any public place. In the previous act, it was 100 meters. Now where it has been increased to 500 meters. This is in line with the national liquor review process, where they are also proposing 500 meters. So our new act has already actually introduced that. So we'll no longer issue a license if a liquor outlet is within 500 meters of a school, a church, or a public transport. We are also doing away with on and off license category, which is your typical tavern, where you would allow people to consume alcohol on premises or buy takeaways. So we will no longer have that license category. From now, we'll only have, it's either you have on consumption or off consumption. The next slide, please, Kelvin. These are the key business operational areas of the Eastern Cape Liquor Board that are prescribed by the legislation in order to address the nuances of the regulation of liquor industry in the province. They include licensing, which is really about ensuring that the due process is followed in the issuing of a liquor license, and social accountability, that is more about designing or conceptualizing anti-alcohol abuse programs to ensure that we mitigate against the excessive consumption of alcohol. Compliance and enforcement is another key or core business area within the Eastern Cape Liquor Board that is seized with the responsibility of promoting compliance with the trading conditions amongst liquor traders. Yes, Kelvin. Next slide, please. This is our harm reduction strategic approach, where we have identified about 4 areas for our intervention, which include underage drinking. Underage drinking is reaching alarming levels in our country, so there is a need for a concerted effort to try and address the challenge or the scourge of underage drinking in our communities. So it's one area that we're paying a special attention. We're investing quite a lot of resources in making sure that we fight or we alleviate the challenge of underage drinking in our communities. And in doing this, we work with schools and communities. Another area of intervention for the Eastern Cape Liquor Board that has actually been identified is drunk driving. As we all know that Eastern Cape roads are known for high road fatalities, and many of those fatalities are attributed to the abuse of alcohol. So we also focus on drunk driving, targeting road users and communities. Another area of focus for us is fetal alcohol syndrome, which is what we are really discussing today to come up with a strategic approach on how we can deal with this health hazard in our communities. So this is an area that we have actually identified as an area that requires a focused attention. The 4th one is binge drinking, where we encourage responsible consumption of alcohol amongst communities and also educate liquor traders about responsible consumption. But also we educate our communities about their role in the whole process of liquor regulation. They should know what their role is as part of the community. We also have, put together some mechanisms to ensure that the harm reduction, our harm reduction strategy has got an impact. For instance, we have identified the importance of research, generating scientific data, and also the importance of promoting social and economic activities within the communities, so that our people can have something to do, because often people will end up consuming alcohol excessively because they don't have anything to do. That is the only recreation they have in their communities. So we promote various social activities and economic activities within the area, so that we can reduce boredom, and also to build capacity through galvanizing stakeholders, stakeholder partnerships, to ensure that we supplement our capacity so we can increase the footprint in the province and make the necessary impact. But more importantly, we are building an informed society. We intensify our awareness and education to ensure that our communities are informed on how to actually relate to alcohol, how to use alcohol responsibly, so that they can also have adequate knowledge to make informed decisions. Next one, Kelvin. Here we just want to illustrate the distribution of the liquor outlets in the province of the Eastern Cape. Importantly, currently we have more than 7,500 active liquor licenses in the province, and they are disproportionately distributed. As you can see on the map, there are areas that have over-concentration of the liquor licenses and the areas where they are sparsely spread. For instance, towards the bottom end of the map is the Nelson Mandela, which has an over-concentration because it's a municipality that has got the biggest number of active liquor licenses, followed by Buffalo City, and so on. So this map for us is very, very important because it assists us to identify areas that may have potential for non-compliance and social ills resulting from alcohol sale. The pie chart on the right-hand side of the slide is really, again, to demonstrate the disproportionate distribution of the license categories. We have got 4 license categories at the moment. It's on consumption, off consumption, on and off consumption, and micro manufacturing. The biggest proportion is on and off consumption, which is more than 65% of the active liquor licenses. These are your typical taverns, which are found all over, and this is where we are actually receiving so many complaints. This is the most problematic license category in terms of compliance and social ills. So, and the smallest will be your micro manufacturing. The on and off, as I indicated earlier in my presentation, we have scrapped that one. We'll no longer have on and off. We'll either have off or on. Here, we're just trying to demonstrate the evolution of the relationship that we established with Distel in particular, which actually started in 2015, which is a characteristic of a public-private partnership that has been resilient since 2015 up to now. We're still working together as some form of a social compact. So we started the relationship. They brought in the capacity through Fast Facts, who started to roll out awareness on fetal alcohol syndrome in the Buffalo City in particular. And fortunately, we had already established an MOU with Rhodes University. When there was a need for research, we then brought in Rhodes University to actually assist us with the capacity. Then the strategic outcome of this public-private partnership has been the implementation of the pregnant woman mentoring program in the Eastern Cape for the first time for us to implement this kind of a model, and then the research, which is going to be presented by Professor McLeod just soon. Here, just to reflect on the initiatives that we have actually taken as part of trying to deal with the issue of fetal alcohol syndrome in the province, but we do note that we do not have adequate data on fetal alcohol syndrome as a province. The only study we had is the study that was conducted in the Nelson Mandela Metro. So there is a need for more scientific investigation on the fetal alcohol syndrome. However, we do have some reports, stories, personal accounts, and so on, some experiences, our own observations that show to us that there is very limited understanding of the extent of the damage that the consumption of alcohol during pregnancy may cause to a woman or to an unborn baby. And also the fact that the government does not pay adequate attention to fetal alcohol syndrome, which should really be a concern, which is the reason why there is very low awareness amongst other things. And also we have observed an increasing rate of alcohol consumption amongst young women in particular, which is one of one of the risks that has to be managed immediately. And again, the normalization of alcohol consumption in our communities, where alcohol consumption is becoming so embedded in our culture. The fact that there is no policy framework around fetal alcohol syndrome should be a concern to all of us. So there is no coordinated effort to actually deal with fetal alcohol syndrome in the province. And the proliferation of the illegal outlets, again, which makes it easy for our people to access alcohol. So that's another big challenge. Challenge for us, the mushrooming of the illegal outlets all over in the province. But in terms of our interventions, we're conducting quite a number of information sessions in communities, working with various partners, using various media platforms so that we can reach a diverse audience. We work with schools as well to convey the message on fetal alcohol syndrome. We work with maternal facilities. In conclusion, it is our view that there is a need for a more collaborative efforts we need to ensure that there is a clear ownership of this of fetal alcohol syndrome in the province. And also a multi-sectoral coordination is going to be very important to ensure that we mobilize various stakeholders and community-based organizations. And also research is going to be very important so that it can inform our interventions. And we believe that it's important that we replicate the pregnant woman mentoring program in the province, which has been implemented in the Buffalo City. It will be quite of interest to us to have it replicated elsewhere in the province. And the need for a policy framework, again, we think there is a need for a clear policy framework on the fetal alcohol syndrome. Thank you very much, Chair.
Thank you very much, Doc, for that presentation on the work of the Eastern Cape Liquor Board. Ladies and gentlemen, while I'm getting the next set of slides ready, I will just be introducing our next speaker, which is Ms. Nontundiso Nzimande, who is with Fast Facts and will be sharing with us the project that has been rolled out in the Eastern Cape with the Pregnant Woman Mentoring Program. Just getting slides ready.
Thank you, Kelvin, and good morning to the meeting at large. Whilst Kevin is still helping us with the slide, I'd just like to say that I am Nonzindiso Nzimande. I'm a social worker from Fast Facts here in East London. Briefly, I'm just going to give an overview of the work that we do on the ground as Fast Facts.
Slideshow. Let me start.
Okay, please go to the next slide.
I just want to get on full slideshow.
So just a brief introduction. Fast Facts is a non-profit organization that focuses on the prevention of fetal alcohol syndrome. We started being operational in East London in September 2017. The areas that we focus on were as a result of the base study conducted by the research psychologists from Rhodes University. So they indicated 3 areas with the high prevalence of alcohol consumption, and those are the areas that we are currently focusing on. Okay. So the areas that we currently focusing on are Tanzania NU8 and NU17, and also Mzanmomhle in Kunubi. Okay. So we have 2 trainings that we have 2 programs that we are currently running. The first one is Train the Trainer, and the next one is Pregnant Women Mentoring Program. Within the Train the Trainer, we focus on awareness campaigns. So we work with the community members who are actively playing a role, either being social workers from DSD, being local government workers, community health workers, and unemployed youth, and many other people. So what we do is we train those individuals on fetal alcohol syndrome so that they may have the information and also convey the message within their workplaces and whenever they interact with community members. We collaborate and have partnerships with different stakeholders. We work with radio stations, social development, Masitete, Latita, Giving Living Hope, Masbamsane, CMR, Department of Health within the clinics and the hospital, and also local government. Okay, so we're going to talk about the awareness campaigns that we do. We work with Department of Education when they're doing their regional youth camps, they invite us so that we may educate the people on fetal alcohol syndrome. We go out there within Buffalo City, mainly on the areas that I've mentioned above, but also outside of those areas. So we go to liquor outlets, educate the owners on fetal alcohol syndrome and the importance of pregnant women not drinking alcohol. We do outdoor awareness campaigns as well. Before lockdown, we were doing the malls, the ranks, the churches, and within lockdown, we still did awareness campaigns outdoor, and on the picture on the left is one of the campaigns that we did. We collaborate with Eastern Cape Liquor Board in many of their awareness campaigns. We also go to the hospitals, the clinics, and educate the staff on fetal alcohol syndrome. We found through our interaction with them that there's actually a lack of information on fetal alcohol syndrome, and I can imagine how that it is, because they are the main people that we depend on to convey the message. So it's been really, really eye-opening to find out how much lack of information there is. Okay, and then also we go to the areas in Tanzania, collect and gather together the early childhood development practitioners, because we feel that it is also important for them as they're dealing with young children to be aware of fetal alcohol syndrome. Okay, we also use different media platforms, including radio. We go to schools, sometimes on request of the principal or the in charge, and sometimes we go because we just work with schools as well. We do awareness campaigns in clinics around Buffalo City, also on request, and mainly on the areas that we focus on. And lastly, on the train the trainer, we do awareness campaigns on door-to-door awareness campaigns. So we go to people in their areas, in their homes, our community members, and we educate them on fetal alcohol syndrome. Then we go to the pregnant women mentoring program. Every April, we recruit 60 pregnant women. And those women must be using alcohol, they must be using drugs, they must be pregnant, and they must be on their first trimester, or must be at risk of consuming alcohol. So we meet with those women every month, once every month, in a form of a group, and educate them on different topics, fetal alcohol syndrome, alcohol and drugs, pregnancy, gender-based violence. Throughout the interaction, we try and find out the issues that are underlying and are causing them to consume alcohol, and we try and focus on those topics. They also have mentors. We have 20 mentors, so each mentor has 3 pregnant women that they are mentoring, and those women must be neighbors, they must be and reachable and accessible on foot. The mentor must not take transport to get to their pregnant women, and each of them visits these pregnant women 3 times a week, just to give them support and to assist them with whatever issues they may be facing. And we find that these women depend so much on our mentors, because there's a big need for a form of support, especially when you are pregnant and experiencing challenges. It really helps to have the mentor so that they may maintain their sobriety. The mentors are also trained so that they may be equipped, so that they will be able to take this take on this load of mentoring the pregnant women. The social worker also conducts home visits. Please go back. The social worker conducts home visits to all the 60 pregnant women. In 1 month, the social worker conducts 30 home visits. And this is so she can provide individual therapeutic sessions to the pregnant women. Here it was now during lockdown, so we still had to keep our distance, but at the same time, we needed to interact. The social worker also provides, sorry, Kelvin, please go back. Yeah. Psychosocial support counseling sessions for the mentors now. The mentors, even though they are trained as well on different topics every 2nd month, but they also need psychosocial support in the form of debriefing. Sometimes the issues they deal with when interacting with the pregnant women are overwhelming for them. So the social worker also has to visit their mentors and help them to cope with the load that depends on them. Okay. Now we're going to go to the results and outcomes of the last year, which is 2020-2021. So initially we had 60 pregnant women that we had recruited in April, and all of those women were consuming alcohol and they were pregnant. So 53% of them, of 53 out of 60, which is 83% out of the pregnant women, totally stopped drinking alcohol during our observation and during our interaction with them. And 4, which is 7% of the 60 pregnant women, started drinking less. And 3 of them never stopped drinking. Okay. Out of the 60 participants, 17 were teenagers, and only 2 of them were still at school. With their employment status, only 4 out of the 60 pregnant women were employed. 56 of them, which is 93%, were unemployed. Okay. So our challenges are mainly shortage of staff. We only have 1 social worker. We have 60 pregnant women. We have 20 mentors. So it's a bit of a challenge, because when you do the home visits and family conferences, a lot of other people are involved, including the families, the friends of the pregnant women. When you're dealing with the underlying issues, we do it holistically. So with interacting with the pregnant women, we also interact with them, with their families and everyone who is involved. So it just becomes a lot for only one social worker. Our other concern is definitely sustainability of the program, because as much as we see and observe a lot of positive results, but I think the future is not guaranteed. And we have so many pregnant women who want to come to the program, who want to be part of the program, but we have to limit the numbers because we are understaffed. But on the positive note as well, we would like to thank all of our stakeholders. We work with a lot of NGOs, and we request them to come over and treat the topics which are their main focus on our trainings with the pregnant women. And they've been so helpful, they've been so hands-on, and it's been helping the pregnant women with so much information and growth, and it just makes a lot of difference. We definitely couldn't do this alone. And lastly but not least, we would like to convey a word of gratitude and to our funders, which is Distel. They've been there since the beginning of these two programs here in Tanzania since 2017, and we are really, really grateful. Thank you, Kelvin.
Thank you so much for that informative presentation, sharing with us how the program is implemented in the communities. Ladies and gentlemen, I am sensitive that we're running over our agenda, so I'm not going to waste any further time to introduce our next speaker and our last presentation, which is from Professor McLeod from Rhodes University. And Professor McLeod is going to be sharing with us the academic research, and then we'll be having a comfort break before we go into the panel discussion. Professor McLeod, if I can, oh, you're on camera. I just want to share your presentation. And let's go from slideshow. Start. Professor McLeod, over to you.
Excellent, thank you. So yeah, my name is Katrina McLeod, and I head a unit called Critical Studies in Sexualities and Reproduction at Rhodes University. I just want to acknowledge the other researchers who formed part of the team that did this research. Their names are there, and two of them are in the workshop, Sibongile Matabese and Nontozamo Tsetse, just to acknowledge them. Next page. So we conducted 3 interrelated studies in support of the FASFACTS program. The first one is a quantitative study, and we looked at alcohol use during pregnancy, in particular through antenatal clinics. The second one was a qualitative study where we interviewed mothers or family and partners' narratives of pregnancy support. And these were of people who had drunk alcohol during pregnancy. And then the final study is a formative assessment of the FASFACTS intervention. A formative assessment asks the question, how can things be improved? So I'm going to speak to each one of these studies in order. The first study, the quantitative study, we did a baseline and an end-term survey. The baseline, we went to 16 clinics in Mdansani and Gunubi, and we conducted the survey. On the basis of the results of this initial survey, we outlined 3 sites that had higher drinking levels than the other sites. And those 2 then became the intervention sites, and the other sites became the control sites. So in the intervention sites, obviously the FASFACTS went in there and it did their various programs. And then at the end, we retested in all the clinics that we'd been to previously so that we can compare the areas where there was an intervention and where there was no intervention, to see what changes had taken place within the communities. The people who were the participants were pregnant women attending antenatal clinics over a 3-month period, both at baseline and at end term. And they were the health service providers in the antenatal clinics administered the TAs and audit questionnaires. What was very interesting in the baseline results is that 2/3 of the sample reported not drinking at all. But here is the catch. Of those who did indicate that they drank, they spoke about high levels of risky drinking. So 17.8% of the full sample, or 81% of those who reported drinking at what is viewed as risky levels. The other important fact here is that a lot of them engage in what we call heavy episodic drinking. This is the binge drinking, where people have a party, or it's over a weekend, or there's an occasion or whatever, and they'll drink 6 or more drinks per occasion. And it's this kind of drinking that is the most harmful to health in general, but also in terms of pregnancy. So 6.8% of the whole sample, or 31% of those who reported drinking, spoke about engaging in heavy episodic drinking. Next one. So if we compare our stats to other studies, on the national level, there's been equivalent kinds of studies done in Cape Town and Limpopo, also looking at antenatal clinics. And we find that the drinking rate, reported drinking rate, is lower here than in Cape Town, as is the risky drinking reportage, but higher substantially than that reported in Limpopo. And you can see in other countries where this kind of research has been conducted, that our rate of drinking is higher. We looked at what these associations were. So what is it that the sort of demographic characteristics that are associated with reported levels of drinking? Well, the one is intimate partner violence. And this is a very important factor, which we'll see coming up again in the qualitative research. Of course, with this, it's not sure there's an association here as opposed to a cause. So intimate partner violence can be a stressor that leads to alcohol consumption, and alcohol consumption can also lead to intimate partner violence. The other significant associations were not living with a partner or household members drinking regularly, and those who identified as colored, except for this particular one, the number of participants who were colored in the survey were quite low, so we must interpret that finding with caution. The end term results. Now, what was interesting here is when we conducted the similar survey, we found a significantly increase in reported drinking in the 3 intervention sites compared to the control sites. Now, this puzzled us, particularly because we'd noticed that in the programs, particularly working directly with the pregnant women, that people reported reductions in drinking. So how were we to explain this? Well, there are 3 possible explanations. The one is that the facts awareness raising has resulted in willingness to discuss drinking with healthcare providers. In other words, because people are openly speaking about drinking during pregnancy in the communities and there's been support, that means that people are willing to tell the healthcare provider that they are actually drinking. This must be seen as a positive thing, because we know that in our basic antenatal care guidelines, speaking about alcohol to pregnant women is required of healthcare providers. And but if women aren't willing to speak about it, then the healthcare provider cannot intervene. The other explanation is that pregnant women may view the behavior as widespread and normal, as been spoken about, so therefore it's okay. The other explanation could be that at site 3, where the increase was mostly concentrated, there was a new service provider collecting the data, and she may have been able to speak more openly with the women presenting at antenatal clinics. Going on to study 2, we had 25 participants. Those are women, partners, and family members. And the research questions that we asked is, how do women, partners, or family members, the women obviously, who have consumed alcohol during their pregnancies, narrate the journey of their pregnancy? Now, this research is seen as important because what's extremely important in interventions is to hone the interventions to local cultural understandings. So what did we find from this research? Well, first of all, people spoke about various sources of knowledge. They spoke about families, teachers, nurses, people in the church, telling them about alcohol use during pregnancy. Most felt that they knew about the effects of using alcohol and that such knowledge was embedded in culture. So here is one example of somebody talking about that, where Rosie says, in our culture, it has always been said that a pregnant woman cannot drink. I was told this a lot as I grew up. There were some misconceptions that we saw, like Smirnoff is useful in pregnancy. But for the most part, people indicated that they knew that it was not good to drink during pregnancy. Despite this, they also spoke about struggling to give up and of unsuccessful efforts to stop, indicating the need for support in moving in that direction. They also spoke about any way of obtaining alcohol, like convincing friends to buy alcohol for them, using support, child support grant, etc. The next thing that I want to speak to is how these women explained drinking during pregnancy. Now, it's important to note that we did not ask them to explain themselves to us, but in talking to the researchers, women did feel that they needed to explain why they were drinking. So these are the themes that came up. First of all, peer pressure. And people discussed the social recognition that comes with drinking with your peers, particularly in what we know as a drinking culture within South Africa. And so those who didn't go drinking felt that they were excluded from the friendship circle, and that this was fueled by the high number of illegal taverns in the area. They also spoke a lot about stress and coping, that they used alcohol as a way to deal with stress and to cope with the various issues in their lives. And there was quite a lot, a number of stresses that they spoke to: lack of support from their partners, paternity denial, partner infidelity, rape, losing loved ones. One spoke about a loved one being murdered, family problems and poverty. Obviously, those two are linked. Receiving an HIV diagnosis was seen as very stressful during pregnancy, and something that could then be, you drown your sorrows by having some alcohol. And intimate partner violence came up. So we saw that again also in the quantitative study. What was interesting is sometimes the pregnancy itself was seen as stressful if people felt that it was unwanted or ill-timed. And so they some spoke about drinking heavily in an attempt to induce an abortion. We bring up this thing of shame and stigma because people did speak about shame and stigma, and why this is important is that we know that shame and stigma are barriers to active health-seeking behavior. When people feel shame, they are less likely to approach health seekers, healthcare providers or social workers for help. And so, you know, for example, people spoke about drinking during pregnancy being stigmatized by community members. And here we have this in closer culture again. Pretty says she did a lot of things that were embarrassing. And Lucy says that it is wrong in our culture. You can be called a bad mother. Shame also extended to family members who also had to negotiate the stigma. So we have this statement by one of the participants. My father said I must stop going to school because I had already embarrassed him in the community, and now I was going to embarrass him at school. The consequences of shame and stigma, as indicated by the participants, is that they excluded themselves from particular spaces. And these are particular spaces that could provide support, such as the church. And they engaged in surreptitious behavior, in particular hiding alcohol or drinking in places where nobody was going to see them. Drinking, they said, led to conflict and being seen as untrustworthy, particularly around childcare, and that this conflict may lead to intimate partner violence. There were some positive stories of interventions. So the tangible support provided by a family in terms of things like money, accompanying them to the clinic, helping with childcare, etc., but as well as emotional support. So we have a lovely quote there by Kutle, who says, I sat down with her and told her she must not drink because the father of her child rejected her, because rejection doesn't mean that I am not there and her father is not there. So here we have, on one hand, partner rejection, but the extended family picking up the support requirements. What was also seen as positive is partners spending time with the women and also reducing their own drinking consumption. Also, institutional support, healthcare providers were seen as positive in assisting the women. Church, particularly, it was seen as a distraction, but also at times there was positive support from pastors and church members. Traditional healers were mentioned, as well as social workers, and there we see on the right our Nonsenziso, who spoke earlier. Study 3. In study 3, what we did is we provided some feedback on what does the current research show. And so what can we learn from the literature in terms of the FASFAX program? And we also provided feedback on aspects of the interventions as they took place. So we met during the 3 or 4 years that we were involved with the program. We met quarterly and provided reports on things like the manuals, on the training, and on the performance of the mentors. I'm not going to go into that, except to say that a lot of changes were made on the basis of these inputs. What I will talk about is, what does the literature say about interventions? Now, one of the temptations in interventions is to say to people, you must just stop drinking. In other words, to concentrate on abstinence messaging. What has been found in the literature is that very often those who are most dependent on alcohol are not reached. So we saw in the quantitative baseline survey that a lot of the people are what we would call more dependent. They're risky drinkers and they engage in binge drinking. So often those who are most dependent will not be reached. Also, if there's only abstinent messages, people may fear judgment from healthcare providers and therefore are unlikely to seek healthcare when they need it. They also may feel that their personal circumstances, such as the stress that the women spoke about and their families spoke about, that those personal circumstances are not understood. And sometimes we also had noted this, where people felt that maybe the messages were overstated and sensationalist. We did have people saying, well, you know, so-and-so drank and during their pregnancy, I know that, and their child seems fine. The harm reduction approach, on the other hand, obviously has abstinence as the final goal, but any step in the right direction is encouraged, and people are motivated to take small steps leading to final success. what this does is it helps women to have feelings of self-efficacy, that yes, I'm managing, I'm going in the right direction, I can get there. And what is recommended then is that frontline workers, your social workers, your healthcare providers, etc., engage in motivational interviewing. Now, what are some of the strengths of the model that FastFacts uses? Well, in particular, it harnesses resources of the local community. In other words, they're using what is there already. They also, their approach ensures that the input given remains within the target community. So it isn't the sort of helicopter, we come in, we provide you with the program, then we leave. And the provision of mentors to alcohol consuming women does provide much needed support and assistance. So what is the way forward? Well, training frontline workers in working with pregnant women is very important, and dealing with things like the drinking culture, stresses, trauma, drinking norms, support for those experiencing IPV, providing a harm reduction, motivational interviewing, and working with gender norms and trying to reduce stigma. There are multiple ways in which healthcare providers at the front line and social workers, community health workers can be trained to assist in this process. Obviously, partnerships, and this is, I think, part of what this workshop is about, that partnerships across various sectors is important, as well as working with the factors that are associated with drinking during pregnancy. Finally, we have got 3 publications based on this work have appeared so far. The first one that you see on the top left-hand side is published in the African Journal of Reproductive Health. The other 2 are published in social work journals. So the first one is an international social work journal, and the second one is in a local social work journal. The idea with this is that the insights gained through this research it can reach beyond the immediate group that is working, and can reach beyond the province as well. So finally, just to say thank you to all the women, the healthcare providers, our colleagues from the Eastern Cape Breaker Board, from Distel, from FastFacts, and the community workers and mentors who helped assisting with the recruiting the participants. And if you would like to see the report, the full report can be accessed on our website, and the website address is there. Thank you.
Thank you so much, Professor McLeod. That was very informative, and it's been a great journey in the last the last hour, to see the various stakeholders, to see the role of the various stakeholders in this project, and how also your researchers have brought it all together to concretize the evidence. Ladies and gentlemen, I'm very sensitive of time. We are running a little bit late, unfortunately, so we're going to have a 5-minute comfort break. My watch is now 11:45. We will be back at 11:50, where our panel of the presenters plus other guests will be having a panel discussion based on what has been presented, and also some of the questions that have come through from the Q&A. So we'll be back at 11:50. Please do not disconnect from the call, but go and recharge your coffee cups, go and have a comfort break, and we'll see you back shortly for the panel discussion. right, welcome back, ladies and gentlemen. We are now going to go into our panel discussion, where we have our presenters that will be on the panel as well as invited guests. And the conversation we're going to have around shaping the future of FAS programs in the Eastern Cape. So I would like to start with Sonia from Distel. Sonia, if you can just explain to the audience and maybe share with us why a company like Distel would support such a program like the FastFacts program that has been shared with us in the Eastern Cape, and why Distel has invested in supporting these programs in these communities.
Thank you, Calvin. Yes, as a responsible alcohol company, Distel realizes that we have a responsibility in promoting the responsible use of our products for the overall sustainability of the company as well as our communities. And we realize that when our products and alcoholic products in general are abused or misused, it causes harm, and that we have a responsibility in curbing or reducing that harm or mitigate the harm that is already being caused by the abuse of products. It is also important to us that the products that we produced are enjoyed responsibly by those people who have already decided to enjoy alcohol responsibly. Trying to convince anybody to use alcohol, but to those who have already made the decision, we realize that the responsible use has to be promoted. We do not promote any of our products to pregnant women, not even non-alcoholic products, and we declare the percentage of alcohol in each and every of our products. Over the years, we've already done a lot of work together with our partners in this focus area. So we've been involved with the prevention of FAS over many years. And to us, it just makes sense to keep on supporting and building in this area that we've already had quite some impact together with our partners. And I must say, we have phenomenal partners in FastFacts, in FAR, and also aware.org in terms of the work that is done. We believe in the work that FastFacts does. As I've explained earlier, we've been involved over a number of years, and it's not only through the data and the reports that we receive on a regular basis, but we have seen the personal testimonies of women in the programs and impact that it has made not only on their lives, but also on the lives of their families and their communities at large. The data and the reports are also very important, because this is what we have to use to justify to our board and our management the investment that we make in the project and the change and the impact that it has in the community. So the reports and the data are also important, and this is what we also receive on a regular basis, and the information is available. We are invited to do visits anytime we want to. We are invited to have direct contact with the beneficiaries, and we can talk to them ourselves also, just to find out and to determine whether there is in fact a real impact for them and a real change is coming about. And we also believe in partnering with government and the liquor boards in helping to achieve the national development goals. So we believe in doing that. We believe that we have to do our part to also help make a difference and bring about change, positive change, where there is a need and where we can make that change possible. And that has also been illustrated through our other alcohol harm reduction projects and our other partnerships that we've had with government and various departments of government. So yes, basically, I hope that answers your question.
Thank you so much, Sonia. It does. And thank you for your support and for being pioneers in showing that public-private partnerships can work. A question to Eastern Cape Liquor Board, Doc, a question that came through the chat. You made reference to the new Act of number 4 of 2018 that now has legislation about the distance that a liquor outlet may be to a church, a school, public transport places. How and what is the strategy to address liquor outlets that had received their licenses before the new Act was implemented and that are in the close proximity to churches, schools, public transport places? Is there a program that the Eastern Cape Liquor Board has to address this? And if so, what is that program?
Thank you, Calvin.
Thank you so much, Sonia. It does. And thank you for your support and for your support. And a question to Eastern Cape Liquor Board, Doc, a question that came through the chat. You made reference to the new Act of number 4 of 2018 that now has legislation about the distance that a liquor outlet may be to a church, a school, public transport places. Is there a program that the Eastern Cape Liquor Board has to address this? And if so, what is that program?
Thank you very much, Kelvin. The new act doesn't necessarily make any reference to the existing liquor licenses in terms of their proximity to the schools, the churches, and the public places. However, we are still working on the regulations because it is the regulations that will go into the detail on how each element of the act will be implemented. For now, in terms of the existing act as it is, it would seem that though the liquor outlets that already exist near the schools, near the churches, will remain like that. But what will happen is that the liquor licenses that we will issue from today going forward, we will make sure that we consider this new distance. But I think I must emphasize the fact that it is the regulations that will go into the detail on how this particular element of the distance will then be implemented. But for now, we cannot say for certain whether they will be required, therefore, to be moved around so that they accommodate this distance that is newly proclaimed by the new act. So we cannot be able to say that. But I must also say that, Kelvin, this is the area that we have actually been grappling with, trying to address for the longest time ever. The issue of the distance between a liquor outlet and the school. This is an area that we have actually been receiving a lot of complaints around in the Eastern Cape, where schools and communities were complaining about the fact that we're issuing liquor licenses without considering the distance between the liquor outlet and the school. The legislation that has recently been amended required of us to ensure that before we issue a liquor license that is within 100 meters radius to the nearest school, we serve that school with a form to give them an opportunity to discuss if they agreed with the application of the new liquor outlet within the vicinity of their school. So we largely depended on the school on the school governing body to actually take a decision if, as a school, they agreed to the new liquor outlet being proposed. So if the school has no objection, therefore we have no reason not to grant the license. And that 100 meters, I must explain again, Kelvin, because in some instances you'll find that a school is less than 50 meters for that matter. That 100 meter doesn't mean that we'll not grant the license if the school is less than 100 meters. It's basically saying that it is the responsibility of the school governing body to decide whether they agree or not, even if it's 10 meters away from the school. So that is how the previous act has been. So we're moving away from that now to say from now, at least we'll consider the distance of 500 meters. Otherwise, this is an area that has been very problematic for us, where the liquor outlets would be granted a liquor license very close to school, with the understanding that they will adhere to their trading conditions, only to find that once they start to do their business, they begin to flout the trading conditions.
Thank you. Thank you so much, Doc, for that explanation. And I hope that answers our participants' question. So a question to Francois and the team from FastFacts. So we've seen a great demonstration of how working with community members to become mentors and support the pregnant woman during the Pregnant Woman Mentoring Program. And that's been very evident through your presentations and validated by the research that the professor has presented. The question is, how important is it that once an organization like FastFacts has done this intervention, what is the strategy to empower the community to continue the program on their own, so that allowing you to move to the next community, so that the program becomes sustainable within that community? Is there a strategy? And if there is, can you share that with the audience?
Kelvin, I don't know whether you can see me now or not.
No, we can't, but we can hear you, Francois, so go ahead. Francois,
Is
we
that
can hear
okay?
you.
Yeah. Kelvin, that is, can you hear me?
Yes, we can hear you.
Can't you hear me?
We
Okay,
can
great.
hear you, Francois.
It is, I wonder now. You can,
Okay, we seem to be losing Francois. Does any of the other team members from Fastbacks want to answer that question for us for the audience?
Nancy, do you want to go first or do you want me to answer?
Please go first.
We've definitely got a strategy in place here, Calvin. I think Francois wanted to share quite a bit about it, but we've been becoming very involved with the areas in the Eastern Cape where we're working, as well as the Worcester area. But the plan that Francois mentioned that he wants to do is move into all the provinces town by town. And from where we work, I think Professor McLeod said it as well, the effectiveness of fastbacks is specifically the fact that we work with what we've got. So we've got this idea where we want to implement a plan where we go town by town, and then specifically to use the areas or the organizations already involved in and invested in area. Professor McLeod also mentioned the effectiveness of churches. And the idea that we had is to get churches involved and train their youth workers that's already invested in a specific area. This specifically would have been for the BOP program that we extend into the schools. And the idea then is that this youth worker of the specific church in this town will specifically work with one primary school in that area and have a very effective result. The reason why we're moving with what we've got is that lessens the amount of funding that we need. We also use the people or the facilitators who are already invested in an area. So that just makes it sustainable that we can move out of an area and the project can move on. Well, if we take hands with churches that's got more money, they will probably be able to employ these people already and paying them a salary. So they would only be taking hands with us, we'd be training them, and we don't need to fund them for the whole program. But then we also have churches who don't have the funding. And what we want to see is taking hands with these poorer communities and funding them to become facilitators in these specific areas to be more effective and more sustainable in the long run. I hope that's answering your question.
Thank you, Jeanette. Thank you for that. Lisa, do you want to add to that? Is there anything that you can add from working on the ground with the community as far as being able to empower that community, give them the program, train them up, and then move on to the next community? You're at the coalface as the social worker. Do you think this is possible? And if it is, what are the risks and the challenges with such a program?
She said it all, but definitely I can add. There's so much positive results that the reception and what we've been receiving from the communities, they definitely want to assist and help and be a part of it. So we've already, like she has mentioned, we already have people who work for different organizations, who belong to different churches, who belong to different institutions like the DSD, the Department of Health, who are collaborating and working with us in making sure that they convey the message. And even when Fastback is not present in that area, we have someone there who knows about fetal alcohol syndrome and who is able to actually convey the message. But obviously, without me being forward, this is one of the reasons that we are here, that obviously we'd like to see and receive more assistance, example from the government, if they could find us and make sure that fast fix is sustainable, and the work that we are doing is going to be here for a very, very long time.
Thank you so much. Thank you very much. Professor McLeod, over to you. The presentation was a high-level overview of the research, and obviously the research is a lot more in depth. But for you, what is the biggest takeaway? Well, two things. What is the biggest takeaway and success that you can talk about having done the research from an independent perspective? And then secondly is, how do we replicate this successful program in other communities, not only in the region, but in the country?
Yeah. I mean, I suppose there's multiple successes in the sense of you know, the support and the interaction that is happening on the ground, and to watch the kind of processes within the communities and how they work with this particular model, which, as I say, is the model of training people in the communities, of providing mentorship to people who are struggling is a very good model. I think the challenge is scale. You know, this is 3 sites in Buffalo City, and you know, that's just Buffalo City. You know, there's many more sites you could do in Buffalo City, let alone the rest of the province. What we also don't know is, you know, does the alcohol consumption during pregnancy differ in urban and rural areas? You know, would there be different needs that people have if they're living in different circumstances? And it's, you know, this is one of the challenges, I think, with any program, is you can take kind of general recommendations that we see in the literature, etc. But all programs need also to be located within communities and need to speak to the particular issues within that community. So one of the things that I think is important in terms of sort of rolling this out is to get a better sense, I suppose, in communities other than Buffalo City, what the needs are, what are the possibilities in terms of interventions, and how to think a little bit out of the box. So for example, I see one of the questions is around working with families and partners. So is there the possibility of working with groups, for example, that work with men? So you think, for example, of Sonke Gender Justice, that does a lot of work with men and the notion of masculinities and what that means. And so you take an intervention beyond the, in a sense, target person, which is the pregnant woman, and locate them within a community and work with the communities. And a very key factor in that is the gender norms that play themselves out, as we saw, paternity denial, all of that kind of thing, the intimate partner violence. Working with men would be an important thing. But finally, I think in terms of sort of sustainability, it is about extending it to people who already have jobs in interacting with pregnant women. So we think, for example, of your healthcare providers who do the antenatal care clinic work and who are supposed to speak about alcohol. How are they speaking to these women when they come in about alcohol? One of the things that we know from the research is that women often fear going to clinics around sensitive issues, whether it's looking for contraception or speaking about anything related to sexualities and reproduction. They often fear judgment from the healthcare workers. And so working with training your antenatal care workers to not be judgmental, to work supportively in this motivational interviewing fashion would be one step that you could do. training your community health workers similarly in working with it. So in other words, people who are already in the system, but just in a sense, giving them the skills to work in a constructive and harm reduction way with pregnant women. And obviously that's your social workers in the Department of Social Development, your social work assistants, etc.
Thank you so much, Professor. That's a lovely answer. And I think you have given us lots of food for thought and some great ideas. But always the challenge is funding. And I do think that the one thing that I'm taking away is that it's so critical that one needs to source additional support and funding to do further research, because the research just validates the impact. And the program is so important, but without that research to validate it and to quantify it, it makes it that much more difficult to be able to measure. And on that note, I'd like to invite our representative from the Department of Health. I'm not sure if they are connected. If they are, if we can ask you to unmute, and if you can put your camera on, just to take a question from the floor. Hi, how are you?
I'm fine, and you?
Good, thank you. Lovely. Thank you for joining us, and lovely to have you part of this wonderful discussion.
Thank you.
Just a question and it leads into what Professor McLeod was talking about. So the Department of Health plays such a crucial role in primary healthcare and prenatal across the country. Fetal alcohol syndrome and pregnant women mentoring programs we've heard this morning are very, very important. Can you maybe share with us just a little bit on how we can strengthen the relationship between the Department of Health, civil society, or the charity sector that's running programs, and the funders, to make sure that we're all working closer, and how we can have greater support and greater collaboration at community level with your community clinics and your community primary healthcare workers?
Thank you, Kelvin. Firstly, I want to thank Dr. Msia for inviting me to the meeting, and I also want to thank the speakers that were talking about FAST, especially FAST facts and the others. Although I had some challenges in connecting and I was disconnected many a times. Firstly, I want to say I was shocked when in the way forward there was an issue saying that the health professionals at facilities are saying they lack information on FAST facts. I was shocked about that issue, because one of our roles, especially the managers at provincial and at district level, we've got a role to train all health professionals from different categories, the doctors, the nurses, and the other categories pertaining to alcohol consumption, because I think all these, the FAST fact issues, they start from the beginning of drinking alcohol. Since I started being a nurse, all our facilities, it's one of their roles. There are days that are set aside by the department, whereby the health professionals within the facilities have the role to do antenatal clinic. In the antenatal clinic, there are women that are pregnant. And also during our family planning health educations, we also do campaigns by health educating even the girls that are attending family planning, because we've got a saying that in order to avoid these FAST facts, we should start from the girls that are doing family planning. You educate them before they are being pregnant that they should not drink alcohol. As you know, that as health, we've got the different types of prevention. We've got primary prevention, secondary prevention, and tertiary prevention. In primary prevention, it's where we educate all women, including the childbearing ages, that they should not engage in alcohol, because at the end of the day, there will be effects that will affect their unborn babies. So that is our role as Department of Health. health educating at facilities, and also we do have the school health nurses that are visiting the schools and do health education on these children whilst are at school. Although at the period of the pandemic that we had stopped those visits in schools. Otherwise, one of our activities as Department of Health, we've got school health nurses that visit schools, and also the nurses at PHC level, they do health education on antenatal clinics. And also thirdly, we've got health promoters that are at community, they visit community health centers and primary health care facilities. And they even go at the level of the villages to do e-health education talks as per e-health calendar. So that's our role as Department of Health. And lastly, as Department of Health, we are working hand in glove with other departments, as we have already said from the beginning, that no department can attend to this alone. We need a collaborative effort. So we do have a forum. In the forum, different departments have got different approaches to attend to this. And so health is also having the strategy of harm reduction, where also we are also doing awareness campaigns. Thank you.
Thank you so much, ma'am, and thank you for sharing what sounds like a holistic integrated program in your department. But we also do recognize that no department and single entity can do it alone. We know there's multiple challenges, and it's not only one healthcare program that your team are working on, they're working on multiple programs at any one time. And I'm sure with the last couple of months or the last year and COVID, you've been stretched even more than you've ever been stretched before. So we acknowledge and thank you for joining us, but also for the important role that your department plays in providing healthcare to our communities.
We are also open for partnerships, but I think the NGOs and the other departments, they need to meet with the higher officials so that we do have something that is service level agreement that we can work together.
Thank you, ma'am. And that's a wonderful proposal, because I think that's what's important. And that's a great takeout from today, is that recommendation, because if we can get that commitment and service level agreement in place between all the stakeholders, not only the NGOs, but also the private sector that are funding the NGOs, government, the NGOs, the greater community, I think that we're on the road to greater things. So thank you for that recommendation, and we will definitely take cognizance of that and take that as an action point from today. So thank you for that.
Thanks.
Doc, has the colleague from Department of Social Development managed to join us? I know he was having difficulty connecting.
Yes, I'm here, Kelvin. I just have a problem with my camera, but you can hear the voice.
Thank you for joining us. I couldn't see the name. That's why I had to ask the question. So my apologies. Thank you, sir. From Department of Social Development's perspective, you obviously play a different role, but a complementary role to what Department of Health is doing. Can you share with us, from your experience of the presentations this morning, what can be the takeouts in, again, a closer collaboration with the Department of Social Development, and also the Department of Social Development's role in helping us as stakeholders to address this concern and reduce the amount of FAS and FASD in our country?
Thank you, sir. Good afternoon, colleagues. I'm Andy Lemankai from the Department of Social Development here in the provincial office. I must first just appreciate the presentations from Distel, Eastern Cape Liquor Board, and all colleagues, including the professor who just spoke to us. Well, clearly there are a number of areas for collaboration. Quite impressed by the work done by FastFact in the Eastern Cape, specifically in the Buffalo City Metro. I believe the program can be rolled out to other parts of the province, and obviously with the support of government. and other stakeholders, including the private sector. And internal in the department, we started having that discussion to say, how do we then support the program that is already implemented in that Buffalo City Metropolitan Municipality. But also, I think one of the restrictions, obviously, is the limited resources that are available. But there are other ways where we can collaborate. I'm quite interested in the Train the Trainer program because as social development in all the district, in all municipalities, we have social workers, social auxiliary workers that can be trained on the program, and we ensure that it's accessible to all people in the province. And through our research component within the department, and see how can we then get assistance from that. But other than that, Chair, as a department already, we are working in collaboration with FastFact and other stakeholders around prevention. We do a lot of school-based prevention and also focus on out-of-school youth through our Kimoja strategy. And we're also supporting a number of NGOs that are rendering both your inpatient and outpatient treatment services. So that's the work that we do as a department. So clearly there's a possibility of us supporting this program and collaborating with other social stakeholders that are working in this area. Thank you, Chair.
Thank you so much, and thank you for joining us. We really appreciate your time, and we also acknowledge your presence and contribution. It's also recognized that we appreciate that, like every other government department, you have a lot on your plate. And I think also with the impact of COVID-19 and with the unemployment rate rising and all the other challenges we've experienced in the last couple of months, we do acknowledge that social development is doing amazing work. So we thank you for joining us today and contributing, and also reaching out and being open to the conversation and future collaborations to enhance, as you said, you're already working with FastFacts, but how do we enhance that? So thank you for that. My last question is back to Dr. Masia from the Eastern Cape Liquor Board. Doc, how do we get the liquor license owners, if I can use that terminology, in the communities to become advocates and more involved in prevention programs and education and awareness programs around FAS and pregnant women drinking and their spouses and family? How do you have any suggestion of how we can get to that level through your organization, which is the body that obviously has that data and works with those organizations every day? Do you have any ideas or suggestions of how we could implement something like that with such a program? We're getting them to become active stakeholders in the community around prevention and awareness. Doc, are you there? Dr. Masia? Oh, you're on mute. You're on mute. There you go.
Thank you. Sorry for that, Captain.
It was the famous quote
so much.
The famous quote of 2020. You're on mute.
Thank you, Kelvin. You know, before I answer your question, perhaps I just need to point out that, you know, our view is that government response to the fetal alcohol syndrome prevalence in the Eastern Cape in particular at the policy level is unclear. And in all intents and purposes, it is inadequate, I must say. And this has actually led to, you know, the lack of holistic and coordinated effort in trying to actually fight and manage the fetal alcohol syndrome in the province amongst various stakeholders. And, you know, the reason why I am making that preface is because liquor traders are part of our critical stakeholders. But our view is that if there was a clear policy framework on how to holistically coordinate fetal alcohol syndrome in the province, we would clearly have a clear direction on how to mobilize whichever stakeholder is affected around the management and the coordination of fetal alcohol-related interventions. Yes, we can mobilize liquor traders. In fact, that is what we have actually, the conversation that we have actually started to get into with them. But unfortunately, we don't have any legislated kind of a recourse that would force them to participate in whatever community-based intervention as liquor traders. So we don't have that kind of a legislation. Fortunately, it is addressed in the new act, where they will be required to pay or to contribute some nominal fee towards harm reduction within their respective areas. So I think we're starting to actually gravitate towards, pushing them towards plowing back into the communities in which they do business. So it's something that we really have to discuss vigorously, Kelvin, to say, how do we mobilize them, how do we galvanize the support of the liquor traders around the issue of the fetal alcohol syndrome, so that they can start to basically play an active role to also fight the fetal alcohol syndrome as the liquor traders. I'm aware that we have coordinated them into various liquor traders associations within the province. And part of what we're advocating in those associations is to say, please come up with your own intervention programs within your communities. What is it that we're going to do? Perhaps what we need to emphasize now is that fetal alcohol syndrome should constitute the major part of their interventions within their communities. Because in the majority of these liquor outlets, Kelvin, you'll realize that the majority of patrons there are young women that frequent these liquor outlets. Recently, we had a video that was circulating of a liquor outlet here in East London, where there was a crowd of young people that were flouting the COVID-19 regulations and all that. But if you look at that video, you will realize that the majority of those patrons are young girls. Very few boys that you could identify in that video. That already tells you that we have a problem in terms of young women consuming alcohol. So I agree with you, perhaps as the Liquor Authority and other stakeholders, we need to find a way to galvanize liquor traders to play a role in the fight against the fetal alcohol syndrome. Perhaps with the blessings of Mr. Mangai, as part of the Provincial Substance and Drug Abuse Forum. This is one area perhaps that we need to start to tease out as the forum to see how we can actually drive it so that the liquor traders can become part of the bigger, of the broader stakeholders that are also engaged in fighting fetal alcohol syndrome.
Thank you so much, Doc. And I think for me as the neutral facilitator, I appreciate your standpoints. I appreciate the robust questioning, but also not just challenging, but giving a solution. So thank you for that. Ladies and gentlemen, I do think that there's been some great recommendations, and I would like to propose that if there's anybody in the audience that wants to get more involved in helping us shape the future of reducing FAS and FASD in the country, not only in the province, but in the country, please get hold of us either through the invitation that you received, because the more people and the more stakeholders we can bring on board from various sectors, the better for all of us if we can work as a coordinated body. I'm going to now move on. Unfortunately, there has been a number of questions which we have not gotten to, and this always happens with events, but I am also sensitive of all of our time, our guests firstly, and secondly, our speakers and our panel, because I know that you've all got very pressing diaries and a lot of you have sacrificed other meetings and commitments to be with us today. So we need to move on with the agenda. What we will do is we've taken note of all of your questions and we will make every effort to get those answered back to you via email response from our panel and our experts. If we can't answer the question, we will tell you we can't answer the question, and we will hopefully be able to find someone that can help you with your answer. So thank you for all of your questions. But before we close, I'm going to ask Francois to just give us a last commentary from FastFacts around, based on what we've heard this morning, the importance of the FAS prevention, education, and intervention program. And then we will go to the final close and allow you to all return to your day. So please give us another couple of minutes. Francois, if you can give us a 2 or 3 minute answer just on reinforcing the importance of the FAS program that FastFacts is doing in the communities. And then we will move to the final close and votes of thanks. Francois, are you there? Francois, can you answer?
Yes, I can hear you.
We can hear you. We can't see you, but it's fine. We can hear you. If we can just ask you to give us feedback on that of why the FAS prevention program is so important around prevention, education, and interventions in the communities that you're working in.
Yeah. The programs, the FAS prevention programs, as soon as the problem of fetal alcohol syndrome is in the community, then it's a different ball game, because then you must start and train communities on how to educate people in how to handle a FAS child in the home, or how to handle a FAS child in the school, or how to handle a FAS adult in the community. That's a different ballgame. What we say is that FAS children, FAS babies must not be born. We must rather prevent this problem in our communities. And it will be also much, much cheaper to prevent this problem than to handle it when it is in your communities. And that is why it is so important that each and every person in South Africa must understand that fetal alcohol syndrome is your business as well, because it does not affect only the unborn baby or the mother or that family or that community. It affects the whole province, it affects the whole country. And that is why it is so important that everyone in South Africa must understand what is fetal alcohol syndrome, and then what role can each and everyone in South Africa play. We are very, very thankful towards the STEL, the Eastern Cape Liquor Board, Rhodes University, that are prepared to come to the table and look at the problem and take hands with institutions like FastFacts and FAR and help us to address this problem in our communities. We are really, really thankful to each and every one of you, as well as the Eastern Cape Liquor Board. The Eastern Cape Liquor Board actually has a huge, huge role to play because of the fact that they have to deal with liquor licenses in our communities. And I see that they, Mr. Mugwebi, Dr. Mugwebi, if I've got it right, that they will not tolerate any longer the on-off category of liquor licenses in communities. I suppose that is the shebeens that they talk about. Now, it is very important that we must have a look at the role that shebeens play in our communities, and what negative effect they have in our communities. And all the communities, as well as the liquor industry, has a role to play to let them know that if there are too many outlets of alcohol in our communities, it has serious problems for the future of our unborn babies and of our children. And we as adults have the responsibility to make the right decisions, and we must not allow liquor companies in our communities where they can influence our communities negatively. So that is why the Eastern Cape Liquor Board has a very, very important role to play in this whole process. And I want also to thank the Rhodes University, Professor Patriona and your team for the research that you did in this project, and I believe will also do in the future for us. It is very important for you to take hands with fast facts so that we can have scientific proof also of what we are talking. And then Department of Health, thank you so much that you say that you are also prepared to partner with NGOs like Fast Facts to address this problem in our communities. We need your help, we need your support, we can't be without that, because you are a permanent structure in the communities, and it is important for us to take hands also with you. And then also Department of Social Development, thank you so much that we can understand that you are also prepared to take hands with us, especially with the Train the Trainer program, where we can train some of your social workers in that program so that they can take the message further. And then for all the other guests today around the table, thank you so much for the attention that you paid today. And we are looking forward to take hands with you. We as Fast Facts see this as the first opportunity that we came together so that we can see how we must take hands with each other in the future. And we are looking forward to that. Thank you so much from our side. We believe that you will also be blessed in the future.
Thank you, Francois. Lastly, ladies and gentlemen, because I am very sensitive of your time, to all of you on the call, just a final closeout and officially close the meeting from Dr. Lucia from the Eastern Cape Liquor Board. And I would like to thank them for putting this together and being the catalyst to bring us together, what would have been in a physical event, but now we've had to move to virtual. So Doc, over to you to give a final close out, a final comment, and officially close the meeting.
Thank you very much, Kelvin. Perhaps let me start by conveying our sincere word of thanks to you, Kelvin, for facilitating and coordinating this session. We are very grateful and appreciate how you have professionally put everything together. We are indeed indebted to you for the successful hosting of this workshop. Thank you very much for your energy that we have always shown since we started this journey together. We really appreciate it. We are so excited that we are here today. And that is because of you. Thank you, thank you, thank you very much, Kelvin. Let me just also thank Reverend Zimande for coming in. I didn't think that we'll also have a prayer, but he just came and did that, and we are very grateful for that. Reverend Zimande, thank you so much. I'm not sure if you're still in the meeting. I wish to also thank Distel for their financial support, for their financial contribution towards this project. We are very, very grateful to Distel, Kelvin. I can inform everyone in this meeting that Distel gave us about 2 million towards this research project, which was a substantial amount of money. So we are very grateful on behalf of the Eastern Cape Liquor Board, on behalf of the Eastern Cape government. Thank you very much to Distel. Special thanks to Sonia, who has been with us since 2015. Has been very energetic, has been very insightful. So thank you, Sonia. Also convey our word of thanks to Jolene, who is actually responsible for signing those checks. So thank you very much. We really appreciate your positive response to our requests. And we hope to continue to work with you in fighting harm reduction in the Eastern Cape. We know this relationship has still a long way to go with Distel. Fast Facts, thank you so much, the CEO, Francois, that we have been with for the longest time ever, with Nonzindi So, who is the social worker that is based here in the Eastern Cape. We thank you, Fast Facts, for the sterling work that you are doing in this province, and we hope we'll remain together in this province and make a dent in fighting the fetal alcohol syndrome in the Eastern Cape. We really appreciate your hard work in the province. To our partner, our valued partner, Rhodes University. Thank you so much for the assistance in the research with Rhodes University. I wish to convey special thanks to Professor McLeod. She has been, with us since and provided a lot of wisdom and support throughout. So we thank you and the entire research team that has participated in this research project. Your contribution to our endeavors is much appreciated, Prof. And we thank you, and we hope the relationship will continue. Our MOU still prevails. Thank you to the entire research team that set from time to time to actually plan around this project to make sure that the project was not failing. I wish to thank everyone. Thank you to my colleagues from Social Development, Mr. Mangai, and Mrs. Nokai. I thank you, colleagues, so much for your insights and your contributions throughout this session. I really thank you so much. To all the stakeholders that participated in this workshop today, I just want to say thank you very much. Please accept our deep, deep, deep gratitude to all of you for agreeing to participate in this workshop, putting aside everything and giving time to us. We really appreciate it. Lastly, let me thank my colleagues from the Eastern Cape Liquor Board who worked closely with Kelvin to make sure that we are here today. And I'm very excited to see that everything has been a success. We should use this platform as the provincial stakeholders, as a launch pad for a more concerted effort, really, to synchronize our efforts to address FAS in the province. As I indicated earlier, we have a challenge of the lack of the policy framework that would actually guide us to conduct and manage fetal alcohol syndrome in a more streamlined way in the province. So we really need to come together and see how we actually collaborate to ensure that as various stakeholders we work together. It's critically essential that we adopt, colleagues, a multi-stakeholder partnership so that we don't end up working in silos. We really need to find a way to come together and seek to resolve the challenge that is imposed in our communities by the fetal alcohol syndrome. But also, you know, as stakeholders, we should leverage on our strengths and competencies, the budgets that we have. How do we pull them together, our resources and assets in trying to solve this problem? I think we need to reach that stage now, especially after this workshop, to say, as various stakeholders that work within this space, how do we bring together our resources? How do we pull together our resources and competencies to actually fight the fetal alcohol syndrome and find a way to work with Fast Facts that fortunately already has got an expertise on the fight against the fetal alcohol syndrome. So I also wish we could also take this conversation, as I indicated to Mr. Mangai, to our provincial drug and substance abuse forum, so that we can really find a way to attend to some of the issues that came out of this workshop. And the recommendations from the research, from Rhodes University research colleagues, we cannot be oblivious to those recommendations. They are very, very important for us to help us redesign and enhance our interventions in the province. So the copies of the research will be sent through to everyone, both electronically and a hard copy. So we'll make sure that everybody receive the research so that we can go through. But I do think that perhaps what we'll need to do, Mr. Mangai, if you agree with me, in our very next provincial forum meeting is to have this particular workshop as one of the items so that we can actually look at it again and see what we need to do about, going forward. But also take a look into some critical elements of the research, particularly the recommendations. How can we embrace some of the critical elements of the research into our own programs? So in those words, Kelvin, I just want to say to everybody, thank you very much on behalf of the Eastern Cape Liquor Board management, the board. So we say thank you for making this is such a success, but also to find ourselves where we are today with the product that we have at hand. The only thing that we need to do now is to say, how do we sustain everything that we have worked so hard to put together as the Eastern Cape stakeholders? Thank you very much. The meeting is officially closed. Kelvin, I'm not sure if you're going to close it yourself or from my side, you will decide.
I will close it. Thank you very much, Doc. Thank you for your support. And ladies and gentlemen, just a reminder that we will share the recording with you, so you will have a full recording of the entire session this morning. If your colleagues couldn't make it, please share it with them. Keep it as a reference point. And thank you to each and every one of you for your participation. And as we said earlier, we will make every effort to ensure that all your questions do get answered via email. And we look forward to having the next conversation to address and reduce fetal alcohol syndrome, not only in the Eastern Cape, but throughout the country. Stay safe, be blessed, have a wonderful day, and we look forward to seeing you all on the next session. Thanks,
Thank you.
bye-bye.
Thank you very much.